Wild Health is about optimizing you. We use genomics, blood work, biometrics, microbiome assessment, many other tests, and a conversation with you to come up with a full health optimization plan. What's the perfect diet, exercise, and supplement plan for you and only you? The Wild Health podcast is about optimizing all of us. Here we cover the cutting-edge science that gives you the base to be able to apply the personalized plan we give you as a patient. To sign up as a patient, go to wildhealth.com. Or if you're a physician or health coach and you want to learn how to do this for your patients, we're happy to help as well. Wildhealth.com for all the information on becoming a patient or working with us.
Hey, everybody. Welcome back to the Wild Health Podcast. This is Carl Seger. I am hosting today, and I'm super excited about having Dr. Peter Fotinos here. He's one of the leading physicians for TRT in the U.S. and with over 15 years of experience in bioidentical testosterone and hormone replacement therapy. He's deeply committed to a holistic medical approach that concentrates on mitigating the effects of aging by maintaining optimal, not average hormone levels. And Peter, I am super excited to have you here because hopefully you can clear up the space a little bit, because obviously this space kind of sucks. It's really hard to think about. But thanks for coming on.
Thank you for having me, Cole.
Yeah, this is you're braving a space here that I don't necessarily envy. I cheat on this regularly because I have an in-house consult with my wife being an OBGYN, and she's North American Menopause Society, practitioner certified. And then she brings in functional medicine aspect to her practice as well. And so I will, ask questions of her constantly because this is hard. And at least for half the population, I ask her. The other half, we deal with this regularly and talk about it all the time. And there's lots of misconceived notions and old dogma in this space that makes it really hard. So, yeah, I appreciate you braving the waters, my friend.
Yeah, I've been braving the waters for over 15 years. Believe me, if this was not real and didn't work, I wouldn't be doing it. So.
Yeah, fair enough, man. So here's the overview we kind of have laid out for today. It is a Herculean effort to kind of get through some of this, but we'll do the best we can. But the plan is to kind of take an overview of the brief overview of roles of hormones and how it plays in men versus women. Talk about benefits of hormone replacement therapy in both genders, but also talk about some discussions around hormone replacement therapy and cancer risk. Talk about estradiol in men, talk about testosterone in women. And kind of along the way, I think we'll go through some myths around hormone replacement therapy. I'd like to hear also not just about, estrogen and testosterone, but also thyroid and thyroid hormones and why you feel like that's the most underutilized hormone. And then talk about what you call the Excel advantage and what that kind of means. But like I said, that's a big list. We might not get through it all, but we might have to have you back if that's what needs to happen. But let's start with, this is a wide question. Like, can you kind of provide a brief overview of roles of hormones and how it plays different roles in men versus women?
Well, essentially, hormones are chemicals in our bodies that actually have multiple effects, which is one of the reasons why a lot of doctors shy away from them. They're usually used to the single hormone or medication doing the single thing, like statins lowering cholesterol, right? So when you have something that can help you lose weight, but also improve cardiac function and may have some other side stuff that it does, it throws some doctors off, okay? Which I don't think it means that they're simple. It just means that it's not within their wheelhouse of how they practice. Hormones have multiple effects. They help with reproduction. They help with reparative function. They help with metabolism. Usually they're secreted by glands, but the overall controller is the brain. We look at them as far as how they help prevent disease and improve quality of life. not like endocrinologists where they look at them as disease processes. I've always been confused with an endocrinologist, which is kind of funny. I don't want to be associated with that group of doctors because they have their role when it comes to, like, for example, diabetes and whatnot like that. I'm trying to give hormones to help quality of life and prevent disease. So that does go hand in hand, but they always feel like we're against each other, basically. So there's two types of hormones you typically will see as a protein-based and a cholesterol-based hormones. Your sex hormones are cholesterol-based, and your thyroid, for example, is a protein or peptide-based. Growth hormones, the same thing. So for women and men, they have very similar functions as far as health related stuff. But as far as reproduction, that's kind of where the difference is. Progesterone and estradiol are the main hormones for reproduction in women, and testosterone typically is the main hormone for reproduction in men, although I'm going to blow that up a little bit with you guys today. So,
all right. I like that. Like where your head's at there. Maybe one of the things I'd like you to kind of dispel or talk about is the term bioidentical. And, my interpretation, and this is, Carl Seger's simple brain, is the term bioidentical got kind of hijacked almost from a marketing standpoint, and is kind of got morphed a little bit to mean something that it doesn't per se. And so maybe talk about that a little bit.
So, it's a lot of people, what I've seen it get messed up with is actually natural hormones.
Right.
Like you can find natural hormones from plants that can kill you or harm you, So I get that all the time. Bioidentical is basically a term that's equivalent to isomolecular, meaning the same structure as the hormone in your body.
Yes.
But it's become a catchphrase, like you said, for a lot of these companies to market, sort of like anti-aging.
Yeah.
You should not be using, if you're a physician, the term anti-aging in any of your marketing because a lot of the medical societies and boards frown upon that. You can use the term age management. You can do that kind of stuff, or preventative health or proactive health. But, this is where I see a lot of mistakes with these companies. And we're not anti-aging. We can't reverse aging. That's what I tell my patients. But we can reverse a lot of the effects of aging. Okay. And we utilize bioidentical hormones because they're the same hormones in your body. Now, this is interesting. The only real source of getting true bioidentical hormones are from cadavers, but that's a risk. You can pass on diseases and stuff like that. We saw this early on before we had mRNA technology with HGH. Most of the kids that needed HGH for human growth hormone deficiency, the stunted growth, they had to use cadavers once back in the 40s and 50s and 60s, right? Because they didn't invent the mRNA till later for those being able to use it for HGH and other things, right? And what they found was, and this was a study that they looked at it, 40 years later, these people ended up developing Alzheimer's disease because in that peptide, in that cadaver's peptide, they were actually transmitting a molecule that was causing Alzheimer's disease. So
what was that? Do you know what that was?
It was like a prion or something of that nature. It was a protein that, So this is the problem with the cadaver. So the truly only natural way of getting natural hormones without having to adjust the structure or anything is from a cadaver, but there's too much risk with that. So we use a plant-based, so we use Mexican yam or soy. Mexican yam and soy have a ring structure called the diosgenin ring structure. It's the basic ring structure of all hormones, right? And then it's taken into a lab. So this is where the all-natural thing gets a little bit thrown off because people will sit there, is it natural? So I want natural hormones. I said, go get a plant. Because you're not going to get it from the bioidentical hormone. Bioidentical hormones have to be made. Okay.
Yes.
And they're put in the lab to be made. So you change the ring structure here, change the ring structure there. It's either going to be testosterone, estrogen, or progesterone, depending on which one you're doing, right? The peptides or the mRNA technology. And then thyroid, actually one of the coolest thing is porcine thyroid is what we typically use. Pigs have identical thyroids, almost identical thyroids to humans. And so we actually use that as our thyroid choice. Now, we have some people that are vegan or Muslim. We usually use something like a combination of levothyroxine and cytomel, or they do have some kind of down feather version. So bioidentical does not mean natural. It means the same structure as the hormone in the body. And when we do that, we can actually predict how the patient is going to respond. And when we get side effects is going to be based on giving too much or too little. If that makes sense. Okay.
Yeah. Yeah. It was kind of that does make sense. And I appreciate you saying that because I often try to I feel like patients get honed in on that, wanting the bioidentical thing, and they are assuming it is natural. And I try to explain that to people is sometimes hard, and sometimes I just kind of let it go, like, well, okay, but this is bioidentical, okay. But I think it kind of takes us to like what, not to get too far ahead of ourselves, but to compounding pharmacies and what those mean and how people are, using, or because I think that's where that originally came from, that term, like compounding pharmacies using it to say like, oh, what I'm making is actually bioidentical. And so how do you mitigate like using compounding pharmacies and the variance in dosing from pharmacy to pharmacy and yeah.
Your good answer. Actually, there's pharmaceutical grade bioidentical hormones. Prometrium, which is progesterone, is progesterone. The only reason why cost is one reason. They can be very expensive. The other reason is when you dose these medicines, one size doesn't fit all. In progesterone or prometrium, and even the generics are bioidentical. I don't use a lot of generic pharmaceutical medicines that are bioidentical, like progesterone, because they come from China and they're inferior quality. That's why they're so cheap. And so when you sit there and say compounding, how do you get the fluctuations up and down? Well, if you look at it, if you get a bad quality from the pharmaceutical, even though they say 85%, there's still a difference. You still sometimes see that drop off with the patient. I've actually had to switch patients from bioidentical commercial progesterone generic to compounded because I got better results, because I know what the sources are from these pharmaceutical companies. I've been using one company for the longest, and I know that I can get the results that I need to get for these patients. So
how do you test for that? Are you just like, seeing how the patient does? And because it was my understanding there was like something like a dose variance of like 60%, depending on which like compounding pharmacy you went to.
Yeah, that's why you have to find the right one, and you want to make sure they're consistent. They have to go through vigorous testing too. A lot of people don't realize that. Even, for example, Acello makes NP Thyroid, and even the company that makes Thyroid, they got in trouble, or they were going after them because they had a variance too. But they have a USP. These drugs are followed, and they're in the NDC. I mean, they're definitely there, right?
Yeah.
So it can happen to drugs even with traditional pharmaceutical companies. Like I think at NP Thyroid back in 2016, they had to pull, like, don't quote me on that date, about 3 batches. And that's actually it's a bioidentical, but it's a pharmaceutical commercial grade hormone. So it can happen at any level. The reason why I like using compounded, it's cheaper. In some cases, it's not. Like a lot of their creams are more expensive than even the injectables.
Yeah.
Right. But, if you're looking at the pill and stuff, the biggest reason why I use them is, some of my dosages, I have to go really high. And if you have a progesterone that's 100, 200, and you got to get somebody to 800 progesterone, that's a lot of pills you got to give somebody, and it's a lot of cost. You could do 2 400 milligram oral bioidentical progesterones and get great results with that. So it's a preference. It's usually cheaper. If you can find a good bioidentical a pharmacy or compounding pharmacy, you can get good results from it. And we've scoured a few, and we have some patients that don't want to use the one we have, and we let them go to some other places. But we tell them, hey, this one's not that great. You want to go to this one because we know the results are better. We follow symptom improvement, right, and how they're doing, and also we do follow blood work. In my clinic specifically, because of the one that's a brick and mortar, we typically will have every 4 to 6 weeks we'll check labs, and every 6 to 8 weeks we'll see where they're at and adjust them and go from there. With Excel Medical and Mel Excel, typically speaking, we'll do the first visit, and you can actually do a lot of hormonal adjustments and changes based on symptoms. But we're going to start. We offer also blood testing if the patient wants to, or if the provider. I don't try to. If the provider's not comfortable doing yearly blood work and they want to do every 6 months, that's between them and the patient, and if they want to do that, okay. But I don't just rely off the blood work because the blood work can lie.
It's one part of the story. It's one piece of data.
Yeah.
Right.
And so it's so much. You see so many people. Like, for example, and I'll talk about this if you want to in depth and stuff. Is they go and look at, you're taking testosterone, you have elevated red blood cells. You got to go get blood, right? That's actually the wrong way to do it. You got to know the context of why the red blood cells are elevated. If somebody has polycythemia vera, which is a genetic disorder of the CHAC2 gene, where you have an elevation in red blood cells, white blood cells, and platelets, they're going to have an increased rate of clots because it's basically a cancer of the blood. It's a cancer of the blood. Cancer people always have higher risk of clotting, right? And so if that's context, then they have to go get blood or take hydroxyurea or some kind of medication to do that. Sleep apnea.
Yeah, I was just going to say, it can also be, sleep apnea.
So sleep apnea, what is causing that? If you got a skinny person with sleep apnea, that's obstructive sleep apnea, right? That's because they have visceral fat in their chest cavity. Visceral fat just doesn't live in your abdominal cavity. It can live in your chest cavity. If you ever looked at a picture of a visceral fat on the heart, it looks so nasty, right? And so you can have it on your lungs. So if you lie down with that fat and it makes you restricted on breathing, right? It's going to make your red blood cells go up because you're going to get hypoxic, right? But what's the cause of them dying? Is it the red blood cells going up, or it's because they have visceral fat, which is highly metabolic, highly inflammatory? It's the root of all aging diseases. It's going to cause you to have hypercoagulable state. It's going to cause you to have heart attacks and strokes and things like that. And that's the cause. But in every single solitary study where you give testosterone, which incidentally reduces visceral fat, you see a reduction in mortality and improvement in cardiovascular disease. And you don't see increasing clots like they say it does, okay? And so it's interesting because you got to know the context. And that so many doctors, they follow the blood testing and that's it. And they don't get the context. What's causing the increase? It's interesting. In 2013, they actually looked at what causes people to increase their red blood cells at altitude. Most doctors are not going to know this answer, or they're going to have the wrong answer. And the wrong answer is EPO from your kidneys goes up, right? That's the idea.
From a result of like low hypoxia from.
You know what the actual cause is? This was a study in 2013. It was in the Asian Journal of Andrology. And what it showed was it looked at people that moved to Peruvian Andes, so went to the Peruvian Andes, people that would then been there long-term and people short-term. In every case, the reason why the red blood cells went up is because those people have a slightly higher testosterone due to the hypoxia. Testosterone had a direct effect on a precursor red blood cell in the bone marrow that caused the red blood cells to go up. That's how it works. And
fascinating.
Yeah, it's because your testosterone goes up slightly. But do you see people giving red blood, blood when they're at high altitude because they have a high red blood cell count? No, you're going to kill them. You can kill them. Yeah,
bad plan.
It's the same concept. It's the same idea. In fact, they've actually shown what it is. It used to be thought it was EPO. It's not EPO. And always I hear it's either the estrogen that increases from testosterone that causes the problem, because what they're doing, and this is a fallacy with traditional medicine when it comes to a hormone replacement, they always equate synthetic hormones to bioidentical hormones. Premarin, which is a synthetic hormone, as a synthetic estrogen, does increase your risk for clots because it has over 10 other estrogens from horses in it that are highly estrogenic that causes blood clots. Whereas if you look at estradiol, it does not increase the red blood clots, but that's what they want to blame. And that was from the studies by Dr. Glueck. If you look, this guy's a piece of work because this study wasn't even a study. It basically didn't have controls. He just gave testosterone to people with thrombophilias and they clotted. What happens to people with thrombophilia? They clot. It's just not, it's not even a study. And yet that's where the black label came from, the black box warning, but they got rid of that.
But it was also about like how it was given, right? Whether it had the first pass effect in the liver and with estrogen.
Well, no, even that, because so this is a good question. Awesome. I like this because you're getting me to my next thing.
Sorry, I feel like we skipped some stuff, but that's okay. Let's get into it.
So in women, when you give estradiol, so they call it the 10-year window, right? So a woman who's less than 10 years out of menopause, if you give oral estradiol, their risk of heart attacks does not go up. Actually, you'll see a 50% reduction in heart attack risk because what happens when you take oral estradiol, and it was oral estradiol that gave the benefit. Yes, the cream estrogen or estradiol is safer because you're going through the skin and you're not going through the first pass to liver. But I'm using quotation marks with safer, okay? because I give all my women, regardless of how many years out of menopause they are, I recommend it for them. I tell them the risk, but I recommend it for them to do oral.
I think we glanced over something for our audience for the purpose of this. Like, can you explain the clot risk with first pass effect versus transdermal absorption? Because I don't think most people know.
It's not a clot risk. It's actually, if you look at it, it's a heart attack risk or myocardial infarction. Okay. When you look at the oral estradiol intake, for women and men, it will increase because of the first pass to the liver, increases an enzyme called matrix metalloprotease. Matrix metalloprotease goes around and basically ruptures mature clots, mature plaques on the blood vessel wall. Okay. This we see in women more than 10 years out of menopause only, typically. Okay. The risk is significant, but it's small. You're looking from a 3 out of 10,000 women in the control versus a 17 to 20 out of 10,000 women where they were given estradiol orally. The risk is only in the first year of estradiol orally. Okay. But after that first year, and by the way, there were non-fatal MIs. Okay. Nobody died from them. But after that first year, if they continued their estrogen, the risk reduced significantly, like women who had less than 10 years out of menopause. Okay. Why is that? There's heart disease and there's heart disease. Okay. The other thing that happens when you take oral estradiol, when it goes through the first pass of the liver, it increases good fatty acids. Okay. The best way to increase your good cholesterol is by giving you oral estradiol because it increases good fatty acids, which increases your HDL, which plucks the bad cholesterol off the blood vessel wall that hasn't matured. And so it reverses those plaques. This is where you get the 50% reduction in heart disease.
So it's not my understanding always, and it sounds like you're saying this is not true, is that when estrogen is taken orally, it's processed by the liver, and that whole process results in increase of several different proteins that involved in clotting, like fibrinogen, factor 7, factor 8, if I'm remembering that right. But it also
that was with Premarin.
Okay.
That's not with estradiol. You look at the study with estradiol that increase those things. It's Premarin. Okay. And this is the problem that happens with traditional medicine.
Okay.
They equate synthetic hormones with bioidentical hormones.
Yeah, okay.
If you look at the two largest studies going on right now with oral estradiol, it's the Finnish and the Danish study. The Danish osteoporosis study has hundreds of thousands of women, and the Finnish study, guess what dose they gave? They given 2 milligrams of estradiol. You know how many women develop clots above and beyond the normal baseline? 0. Go look it up. You'll see. So,
but the original studies, the dosing was way different. Is that what you're saying?
The original studies were done with Premarin, which is a different synthetic hormone altogether. Right. I don't give Premarin.
No, I don't know anybody who does anymore, but maybe they do. But
I just got a patient that did that. It's their provider. They came to me. They were giving her Premarin and she's been on it for like 6 years. And I was like, oh, we got to get you off this.
Was she a smoker too? Because that'd be rad.
No, actually, she wasn't, which is funny. You're right. If she was a smoker, it would have made.
No, I've actually seen that. That's why I say that. I was like, holy.
So we got to make sure, like I said, the fallacy of traditional medicine, they equate Premarin and the study with Premarin. And this is not your fault or my fault. No. It's the way they do the study. They conflate a lot of the name and the terminology. For example, hyperthyroidism and high dose thyroid, they interchange, but they're not the same thing. I actually gave a lecture today to my providers about that. And if you look up a really cool doctor, his name is Thomas Kelly, Tammas Kelly, and look at his studies on thyroid, high dose thyroid. Now, it's funny, he is a psychiatrist. The 2 cases where we use high dose thyroid in traditional medicine is differentiated thyroid cancer, right? Because we want to suppress that TSH so that doesn't stimulate those cancer cells, and bipolar disorder and some other affective disorders. Huh. And the funny thing about it is I want to change my degree to a psychiatrist because I don't have to check blood levels when I'm a psychiatrist. But if I'm a regular doctor, they always sit there and say, you got to check blood level. But if you're a psychiatrist, you don't have to, he doesn't check any blood levels, and he gives high dose thyroid to these. And in the study, it's interesting. High dose thyroid, he did a review of all the high dose thyroid studies. And he basically showed that it doesn't give you the same thing as hyperthyroidism. We have basically confused Graves' disease with high dose thyroid, okay, which is two different diseases. Graves' disease is an autoimmune disorder, but you get it, I get it, but you go talk to an endocrinologist or a regular doctor, they don't get it. They see that TSH suppressed, and they almost automatically think they're hyperthyroid. And I'm like, no, I'm giving you a thyroid. And if you look at the TSH suppression in some of these studies, if you look at the Thomas Kelly studies, you'll see it. It shows that suppressing TSH with a high dose thyroid doesn't cause any negative effects.
So this is super fascinating to talk to you.
Yeah.
So maybe we should back up and talk about let's talk about like who are you doing let's maybe talk about like hormone levels.
Yeah.
And how that changes with age, for example. Like this is something that I wish that somebody would do the study on. Like there's all these, I think we all have this where we're like, why isn't there a study? You think that there's data around like a subject and then you try to go into it and you're like, it's tumbleweeds going by and you're like, you got to be shitting me right now. Like nobody studied this. And from my knowledge base, I don't think anybody's ever done the study to truly like march out and follow men in time and to get like what are standard levels of total and free testosterone in men at different ages to even get like a standard deviation in different age groups. Am I wrong about that? Like, but maybe talk about that in ages.
Let me give you a little bit of history. As far as the American Urological Society Association, as well as the Endocrine Society, before insurance companies got involved in wanting to get a number, their diagnosis and treatment of testosterone was based on signs and symptoms of testosterone. They never looked at a level. If you had signs and symptoms of testosterone, they gave you testosterone. If you felt better, it meant you had low testosterone because the research doesn't show that, right? It doesn't show you what's the number, right?
Well, so. Can you describe why? Because I have my opinions on why that is, like why the numbers. That's phenomenal. A piece of data to me.
Okay,
yeah.
So there's interpersonal and intrapersonal differences between people. Intrapersonal is what changes within you. So your testosterone is going to fluctuate throughout the day. Do you know why they want you to check testosterone in the morning and not at night?
Because that's when it's highest.
Why do I want to know when your testosterone is the highest? I want to know when it's the lowest, right? Yeah. So a lot of people got in this trap about, go ahead, sorry.
No, I was just going to say, don't you kind of want to know both, right?
Yeah.
Like, don't you want both pieces of data?
Actually, really what you want to know is, there's kind of a minimum idea where you want to be. So we got to go into the concept of optimal versus normal. And normal is relative to the patient. Okay. One of the main reasons at the interpersonal is the sexual binding globulin.
Sure.
Depending on insulin resistance, polymorphisms and your genetics on how your sexual binding globulin functions, that depends on how much your total, your testosterone or your free testosterone gets bound up as total, right? That varies from person to person. So that's why you can't predict what this dose is going to do for one person. They've been trying to do this. They've been even trying to do studies where they look at what levels of testosterone improve libido. And they can't figure it out because there's so much difference. So there's that difference. It's also how the enzymes convert testosterone to HDHT and estradiol, how efficient they are. Also, and the most common is receptor downregulation on the surface of the cells, right?
Yes.
The cool thing about that, though, is, and this is what I've seen happen a lot, unlike, when you give a medicine that your body's never seen before, like a pharmaceutical medicine, you'll see a negative feedback and those receptors will drop because it gets overstimulated. The body wants testosterone. The body wants thyroid, so it'll upregulate those receptors. Yeah. So you can force the body to respond. This is why you'll find people having to take super physiologic levels of testosterone to get a response, right?
Yep.
So basically what we see is it varies from person to person. I can have the same body type, same age, same sex person, give them hormones, and they're going to be a completely different treatment plan than the person at the same age and everything else. Sure. It's just because the hormones, there's so much stuff that varies out. Simply relying on the blood work is a bad way of doing it. Because hormones don't work in the blood, they work inside the cells. They have to get inside the cells to do their function. The blood test can give you an idea, but you can't solely look at the blood testing. And that's what we do here in my clinic is your symptoms come first. The blood work is just a tool. And like I tell my patients, you can think of the blood work as a hammer. What I see a lot of doctors using is they think they can build that whole house with just a hammer. You can't do that. You can't build a whole house with just a hammer. You need the whole context. You need what's going on with the patient. So you need what they tell you to correlate with how they feel, you know?
Yeah. Yeah.
And as well as the blood work.
Yeah. I mean, I've always kind of thought of this, and maybe correct me if I'm thinking about this wrong. It's like lab work is one piece of data. It may change how aggressive I am about something with somebody, right? Like if your testosterone is in the tank in 0 and you're 28 years old, I'm going to go fishing for some other cause of that. I'm going to be looking in your brain. I'm going to be getting all kinds of is this a pituitary problem versus like, it's a little bit on the low side, but you have significant symptoms. Let's also look at lifestyle things like what's your sleep look like? Are you overtraining? And you're, 54 years old. Let's look at the greater context. But so it's a tool in the toolbox to look at, to evaluate someone. Is that a fair?
It's a fair assessment, but it's also like everybody seems like the only reason why hormones drop is because of age, right?
Yeah, no, which is not true.
Because now they used to think age was the main cause, but nowadays, guess which was the main one? It's endocrine disrupting compounds. Endocrine disrupting compounds are taking the lead. Yeah, because there's so much chemicals in our food, in our water, in our women's, in their makeup that actually will mimic the hormones or even disrupt those hormones from working properly. And so that's one of the most concussions, traumatic brain injury, PTSD. I saw that y'all did some things with military guys.
Yeah.
I have one of the lowest testosterone I've ever had in one of my patients was 160, and it was in a 25-year-old military. We have Fort Bragg here, and we have Fort Freedom now, and we have Camp Lejeune and all that. He got blown up in IED, and he had head trauma. And if you have a TBI, traumatic brain injury, or concussion, or even PTSD, which is a chemical concussion to the brain. A lot of people think it's a mental disorder. It's actually a chemical concussion to the brain. Your brain gets overwhelmed with all these chemicals, specifically cortisol, insulin, and epinephrine, that it causes this disruption of the hormonal signal. Yeah, we look at prolactin levels look at that adenoma. Yeah. Obesity. Obesity is one of the highest. And during the pandemic, we hit 46% obesity rate. Obesity is one of the insidious ways of dropping hormones in both men and women.
Yep.
Okay.
Do you want to know what the biggest delta change in a testosterone level I've seen was? Actually, I can't remember his age. He was in his 30s. And he, from the first time I saw him, and like testosterone wasn't a discussion really because we were working on other aspect of his health but his wife had a kid. They had a baby. He put on some weight and he was basically not sleeping all the time. And this guy's testosterone, I don't remember the exact numbers, but it was like, whoa, man, like, what did you do? And it was like pretty obvious, pretty quick it was such light. He was super stressed. He was sleep deprived. He'd put on some weight. All of those, his strength training went in the tank because he just didn't have the time. And like all these factors just stacked up. And it was like the perfect storm of I think it was like a 500 or 600 point drop. He had like it was huge. Yeah. It was nuts. Yeah.
And you're going to feel that. I mean, nobody cannot feel that, right?
He felt it all right.
So it's nuts that you see that kind of thing. And the problem just to sit there and think it's one factor that causes it, that's short-sighted. This stuff is difficult. If it was easy, everybody would be doing it, right? So you do have to attack those things. I tell all my patients, and you'll probably agree with this more than anybody, this is not going to work if you don't exercise and diet or having good nutrition, right?
For sure.
The human body is not meant to sit. And everybody's looking for this, magic thing that's going to make you lose weight and stuff like that. No, it's very simple. 3 things that we do in my clinic is diet and exercise. We talk about both of those. And I don't care what exercise you do something you love, right? Because if you're not doing something you love, you're not going to maintain it, right? I can't outrun. I don't like running. If there's a bomb that just got dropped right now, I probably wouldn't even run from it, right? But I do mixed martial arts. I do hits training. Do something you love, right?
Yeah.
Nutrition. The only three things that I've seen that work for diet and exercise, or diet, which you probably know more, but what I've tried, and I do everything that I tell my patients. I'm on hormones. I'm on 4 milligrams of estradiol because I can't get my estradiol high enough to protect me.
Well, we got to talk about that. But keep going.
Yeah. I'm not growing breasts. I'm not crying in kitten commercials, right?
Yeah.
The diets that I saw that work the best, and I am Greek, and I'm not trying to be biased towards this, but is the Mediterranean diet and the keto diet, right? And then the type of way of eating is intermittent fasting and time-restricted eating. And every single one of those, the main culprit that they control and they keep under control is insulin. Insulin is the problem. It's not the sugar, which sugar causes the insulin go up. But if anything that you can keep the insulin down, which makes you gain fat and keeps you from losing fat, that's going to be key. And then hormone replacement. Hormone replacement is one of the missing links for preventative care, because you can go and do all these tests and look at all this, do a screening mammogram and all this other stuff, but that's early detection. That's not prevention. And people get stuck with early detection as being the same thing as prevention. It's not. I've seen reductions in visceral fat that's dropped a person from having a hemoglobin A1C of 10, over brittle diabetic on an insulin pump and everything. I got him down to 5.5 and he's off insulin with giving him testosterone. And there's studies. There's studies that show that you could do that. And the main reason is because you're reducing the visceral fat, you're reducing this waist circumference, which is the main. If you look at anthropomorphically, what are the main things that indicate death? Is your waist circumference. If your waist circumference is too high, you're going to die, because that portends that you have a lot of visceral fat, right?
Right.
So my goal is to reduce visceral fat, which is pretty much all the goal of everybody that comes in, because most people want to lose weight that come and see me, right? And by doing that, not only are they going to feel and look better, we're going to reduce a lot of the diseases of aging.
So you talk about blood pressure, heart disease, stroke, osteoporosis is obviously
Alzheimer's disease.
Yeah. So discussion about Alzheimer's disease, that could be a separate discussion around, the link with hormone replacement therapy and Alzheimer's disease, which I have an opinion about that, but we should talk about that some other time. What about, when patients are coming in to see you, is part of their evaluation getting, if you're like tuned into visceral fat this much, are you getting DEXA scans with, fat mass and muscle mass distribution data with them to like track that? Or are you just...
So I use it. I use InBody, the InBody device. Okay. I realized that actually the cool thing about, you're right. DEXA scans are expensive. We're trying to bring it. I'm trying to get one in. They're not cheap, but the cool thing about the DEXA, it's better for fat and body composition than is even for bone mineral density.
Yeah.
They try to use for bone mineral. I'm like, just because it doesn't show. I mean, you can have an error with the fractions that show that you won't have a fracture if you're bone mineral. Right. But it's better for, but I agree. But I use the InBody machine. It has a visceral fat score. It does about composition by, but it's an impeded system. It's not a radiological machine or anything like that.
Right. So the accuracy of the InBody, to be clarity, like it's not as good, but oftentimes what I'm telling people is, well, when we have that option, I'll get people to get a DEXA scan and an InBody within hours of each other. Yeah. And then if we're going to go back to a DEXA scan, go back to the exact same DEXA scan, because there's machine variants. Yeah. It's same thing with InBodies though. Yeah. So one of the nice things that I'm doing with people, and I don't know if it is, if they come with me with a DEXA scan and I can get an InBody at the same time, then we can track them with the InBody. So we're actually, trying to compare, we have good data, and then we can say, okay, let's track this over time. But I want them to be going back to the same machine.
Well, you notice this when you go use a home scale, right? If you use the health scale upstairs, it's different from the scale downstairs, right?
Sure, totally.
By the way, it's the same thing with blood work. Well, if they're not running your blood work on the same machine, that variation is going to be there too, right? And so this is another problem with blood work, right? So I'm going back to it because I want to show you how blood work can be very misleading. So I like the DEXA scan. We're looking at that at my brick and mortar clinic. It's once we kind of with the telemedicine company, it's going to be more difficult, but we're going to figure that out too. As far as InBody, I've been using the same InBody the whole time I'm on my patients. They don't go to any other InBody machine, and they just get tracked by them at the whole time. And so I get to follow, and it's pretty accurate, because I compare it to other ways of looking at body fat, and I didn't realize how accurate. I was like looking at it, I was like, because I thought it was some new fad and stuff, and we tried it because we needed a better scale than just putting them on a scale. Because losing weight, what if you're losing muscle and gaining fat, right? And your overall body weight's going down. That hurts you. That doesn't help, right? So
yeah, and I mean we talk about this a lot. So I'll do this with, especially around GLP-1 agonists. So so for Ozempic and those type of medications for people, I'm trying to get DEXA scans or an InBody or some sort of data around that to look at their muscle mass as well as their fat and fat distribution. People want, I'm more interested in the distribution, but also their pure muscle mass, because what I've seen and what happens is more as somebody comes to me and they have a DEXA scan is, yes, they have lost weight. And I try to get people to stop focusing on the damn number, but looking more at like, lean body mass is what I'm trying to get people to. And sometimes that maybe even requires them to put on a little bit of weight if we're increasing muscle mass. But what I'll see with these GLP-1 agonists, if people come to me and they've actually increased their fat percentage, the percentage of their body fat, but only because they dropped so much muscle mass. Yes. And so that is like a worse health situation to me, right? And it's also the distribution, what has changed. And I actually think GLP-1 agonists are not a bad medication. I think they're appropriate for some people, but this is like a great example where you want to get, you want to get them adequate protein intake. You want to get them on a exercise regimen, as you said, but also looking at hormone replacement therapy when it's appropriate in people, and that's a part of it.
So metformin does the same thing. You can't build muscle on metformin because it affects the endocrine.
It's hard.
Yeah. Same thing with the GLP-1 receptor agonist. I actually went through with my providers and did the step studies. I looked at the steps. Right now they got 12 of them or 13 of them or something like that. And that was looking at semaglutide for weight loss, right? Mm-hmm. And it was interesting. You did get weight loss, about 15% body weight loss, but it was pure weight loss. We didn't know whether it was, what the waist circumference was. We should know, and stuff like that. So do we know if it's muscle or if it's fat? But the X factor you're saying is correct. But the funny thing about semaglutide in it, once you stop the medicines, the weight comes back, no matter what you do. Now, it was a study with hormones.
Yeah.
So I do have some patients on semaglutide that I give hormones to. I don't know what it is. I'm not doing a study with it, so I don't know if it's going to you're going to be able to maintain the muscle or gain muscle. But you're right. What fat are you losing? Now, if it's attacking visceral fat, I'm all for it. And like you said, a lot of the reason why these drugs are being used right now because they found a way to make a lot of money off them, right? Because they used randomized control trials that showed it worked, and they dumped a lot of money into these trials. So that's why you see it. But any tool that I can use to help people lose weight, I will, as long as it's safe, right? And as long as you're losing meaningful weight, right? Subcutaneous fat, metabolically it's neutral. It doesn't do anything. So you can have a bunch of subcutaneous fat and not be an issue. It's the metabolic and pro-inflammatory effect of visceral fat. That's the fat that kills people. Right. Now women they want to lose subcutaneous. Men do too, don't get me wrong, but that's what they get used to, the subcutaneous. But what my goal is the visceral fat. That's what I'm trying to get. And if you look at the hormones, you can do that with every hormone. So,
well, let's talk about that. Is as far as like estrogen for men and for women, and also testosterone for men and for women, and kind of which is most crucial there, but also like, I guess I just want you to kind of unpack, because when men and, I have patients who are on estrogen and are men, and there's scenarios where that makes sense. But if you tell a man that, they generally will freak out. They will freak out. Like telling a woman that, hey, you need some testosterone. No, you can sell that to him. But telling a man, like, oh man, it goes poorly every time.
Actually, it's kind of funny. Exactly the opposite, typically.
Oh, really?
Yeah, for me it is. Let me explain it to you this way. The dichotomy of hormones came from like rat studies back in the 1950s. Some guy castrated a rat and did some things with it. And he said testosterone's male and estrogen is female. And it's not black and white like that. It's completely gray. And I get tired of it. You know, it's sort of like you ever watch it's been propagated by, you know, media and stuff like that. So you ever watch a TV show and I can't watch doctor shows because you'll see inevitably somebody will flatline and they're going to pull out the defibrillator and defibrillate the patient. So everybody thinks when you get a flatline, you're going to defibrillate the patient, which is exactly what you don't do, right? Well, it's the same thing with kind of hormones. Where you hear somebody, I cringe when I hear somebody, oh, it's too much testosterone in this room. And I'm like, so that means there's women in there too, right? You know, or estrogen. Oh, your estrogen, you're going to cry at kitten commercials or you're going to grow boobs. No. You got to look at the research. One of the best landmark studies is the Finkelstein study in 2013 in the New England Journal of Medicine. It was a randomized controlled trial where they took approximately 600 men and they gave 300 with testosterone alone, and the rest they gave an AI or aromatase inhibitor or estrogen blocker. Okay. You tell a man if you block estrogen and their penis will stop working, you know how many men are not going to block estrogen?
Well, I don't usually come in hot like that when I talk to them about that, but
that's
okay.
exactly what I say. Because a lot of men come to me because of low libido and erectile dysfunction.
Yeah.
And so I say, you're not going to give me an AI? I've said no, because I don't want to make your penis not work any further, you know?
Yeah.
You want to get a man get overall body fat and visceral fat increase? In that study, it showed an increase in overall body fat and in visceral fat when you blocked estrogen. So it's interesting how we get this preconceived idea. And it's funny because traditional medicine propagates that, you know?
Yeah.
And it's not how it is. It's not black and white. The most important hormone in men, that's the sex hormones, and both women and men, is estradiol. Because the active form of testosterone is not testosterone. It does have activity, but it activates the two hormones. One is DHT and one is estradiol. And I have several studies that will show you that even if you increase testosterone and DHT by itself and don't increase estradiol, men don't do better. They do better when they increase DHT, testosterone, and estradiol together. You're not going to grow boobs. That was propagated by a book called The Underground Book of Steroids. Was done in the 1980s. It was reprinted in the early 2000s by a weightlifter, David Duche, I think his name was. He's now dead, probably because he blocked estrogen because it caused him a heart attack or something.
Yeah.
Okay. And they basically vilified estrogen as the bad hormone for men. And it prevented them from weight loss, building muscle and stuff. But in the book, it said, this is interesting, because I'm like, my wife's a lawyer. Okay, so I don't win a lot of arguments at home.
Yeah, no, you don't.
But the cool thing about my wife is when she used to practice, now she works corporate, but she used to practice in, you know, the court and stuff like that. She says, I will always look and see what their argument's going to be. I want to know where they're coming from first.
Yeah. Because
it's easier to break down their argument if you know what they're coming from, and then you bring your own defense or information to it, right? And so I read that book. I read some of the studies that showed negativity with hormones, and I'll show you why that's a little bit wrong, why we got to look at it a bit differently. But in that actual book, it says the most effective hormones, steroids, were the ones that aromatized to estrogen. So why the hell would you want to block estrogen? It says it in the book. I was like, what is this? Why do you do that, right? And so the only other study that I've seen was a 2006 study. So there's a difference between baseline studies. You would agree with this. Baseline studies or endogenous level studies versus an interventional study. And what happens with a lot of medicine, they take baseline studies and they apply it to what happens when you give it. For example, in this study, it was looking at heart failure, and they were looking at estrogen levels at 5 levels, quintiles, right? And the middle level was the normal level. The last two were the low, and the other 3 with the other 2 were the high, right? And they saw a dichotomous relation to heart attacks and death from heart failure in the low estrogen group and the high estrogen group. So they assumed if you give estrogen or you have to block estrogen, that will protect somebody from having heart issues. This is where the stupidity comes from.
Yeah, no.
Estrogen wasn't given. Okay. It was baseline level. So what do you think caused the death in the people with low estrogen? They also had low testosterone. And we know men who have low testosterone are more likely to die from a heart attack and heart disease.
Right.
But what happened to the people in the high? They even said it. The clinical parameters between the people in the low and the high were different. The people in the high were fat. The estrogen they were producing was coming from fat, which went to the brain. And remember, in the hypothalamus, the receptors for testosterone control are primarily estrogen. So that's why I'm telling you estrogen is the most important hormone that comes from testosterone, because it's how we control testosterone that comes from our testicles. Right? And so when they had a lot of fat, this is why obesity is such a bad thing right now. This is why heart disease is still going up. And yet we're controlling cholesterol so much. It's not cholesterol, it's the visceral fat. It was increasing estradiol, going to the brain, reducing the gonadotropin releasing hormones, which reduce testosterone production from the testicles. And that's why they were dying, because they had low testosterone, and the estrogen and the visceral fat, it's not the estrogen, but it was the visceral fat that was causing the disease. And that's why they died. This is where you get, we don't want to block it a lot. We just want to block it a little bit. If you block estrogen less than 50, most people target around 20 to 30.
Yeah.
They say you'll get profound bone mineral density reduction. You'll get profound osteoporosis risk.
Yeah.
You don't block estrogen. You want estrogen into the same level as you were in your 20s, which is the same as a woman, which is between 75 and 100, and I shoot for 100.
So, well, I have a bunch of questions in there. The only thing I would push back on is that I believe that cholesterol is involved with heart disease. I think visceral fat is a reflection of partially of metabolic health, of all these other things.
Okay, so I agree with you on that, but I'll agree with you on that. But let me tell you why. If you look at statins, which reduce, I don't know what your take on statin is. I think they're not the greatest drugs, but if you look at them, you only see an absolute risk reduction of heart attacks and strokes by 2 to 3% with a statin. Your mortality rate doesn't change. You're still going to die at the same age. Okay. If you talk to any cardiologist worth their ilk, they're going to tell you it's not because it lowers cholesterol. It's because statins have a slight anti-inflammatory effect. Okay. The reason that I don't like statins is that it will increase your risk for diabetes. I don't know if you saw that recent review article by 51%. Yeah, 51%.
I see this all the time.
Yeah, 51%. And we knew this is 2001, right? Mm-hmm. So we got people walking around with this number being lowered, right? They think they're protected, but they still have the visceral fat, which is the cause of the disease. The disease process is the visceral fat. The cholesterol is an indicator that something is going on. Simply artificially lowering the cholesterol doesn't fix the visceral fat. And so now we have people walking around this false sense of security that they're protected. And now I can eat whatever I want because my cholesterol is low.
Yeah.
You see the problem there?
I see what you're saying there. I have a little bit of a different take on it. Admittedly.
Okay.
Like I view cardiovascular disease kind of happens by the three things you can control that. Well, there's kind of 5 things that affect cardiovascular disease. 2 of them you can't control. One is your inherent genetic risk, which we don't always understand the complexity of. And the other one is time, because everybody develops some plaque formation over time. However, the 3 things, so what happens?
Well, hold on. Are you talking about people who are on all hormones or off hormones? Because if they're on hormones, you'll see the regression of plaque. You can even see it in the carotid intimal thickness. When you see in studies where you give estrogen in the form of testosterone or even oral estradiol, you see a reduction in plaque over time. Why you see an increase in plaque is because you're losing those hormones over time. It's directly correlated. You could see it.
Well, I would say there's kind of 3 things, and I think hormones play a role in those 3 things. So one is, you have cholesterol, and certain types of cholesterol are more likely to get inside a blood vessel wall.
Yeah, the small particles. Yep.
And most of those containing the protein apolipoprotein B,
which I test. I test at my clinic.
Yeah, sure. And then once but it has to get inside like endothelial damage, right? And that's
but you know, it's interesting. Have you looked at the study? It wasn't how much is on your blood vessel wall. It's how long it sits on your blood vessel wall. So you can have a little bit of apolipoprotein B, but if it sits on your blood vessel wall for a long period of time, it's going to do damage. It wasn't dose or level dependent. It was time dependent. And guess what? The only cholesterol way of getting that apolipoprotein B off your blood vessel wall, HDL. HDL is the only way you can get it off your blood vessel wall.
Well, so
naturally.
I think there is a pure concentration effect, and I think there's a timing of clearing off your blood vessel wall. I don't think those two are necessarily independent of each other, but I was also like, is there an injury to your blood vessel wall which is affected by your metabolic health? Do you smoke? You high blood pressure, like a mechanical,
or you drink alcohol?
All things that cause endothelial dysfunction. And then the other thing is, once it gets inside there, there's an inflammatory process, which is sort of diesel fuel to the fire.
That's why I look at CRP. I look at homocysteine as well. Yeah. So do look at those factors. I also do coronary calcium tests too.
I don't do coronary calcium scores.
Yeah. I see what you're talking about. I saw because what you're seeing with the coronary calcium score is stabilized plaque, right? So you're not really seeing the unstabilized plaque. And I understand what you're saying. They
have about a 15% false negative rate because you have these people who don't have plaque or don't have calcified plaque yet.
Yeah.
And so I actually have kind of gone to using just coronary artery CTAs with quantitative AI because that is where, so here's where I'm going to push back on this, like where I'm seeing actually regression of plaque in people that we're doing all these things on. So reducing inflammation, decreasing endothelial dysfunction, but also lowering ApoB aggressively. And that's where I see stabilization, if not reversal of plaque. And that's where, so.
But what's the outcomes though? Because if they're still
plaque.
Well, no, because you got to look at the outcome studies. Because if they're still fat and they still have the visceral fat in there, but I'm guessing you're getting rid of visceral fat too with what your company does, correct? So you're attacking.
We're not just coming at it with one way.
Exactly. But that's what happens with tradition. What I find is they give them a statin. They tell them diet and exercise, right? Well, I agree with the way you do it. I just don't agree that, hey, statins is you just put somebody on a statin and make them go away. And that's
so. I mean, here's the thing: is that I have people who have apolip. This is not common. Like the rare thing is I have a patient who'll show up, and I actually have a patient, super nice guy. He has an apolipoprotein B of 190, which is bonkers, right? I mean, that's bonkers.
Is it on the blood vessel wall though?
Well, so he has something, and I agree with. That's why I'm saying, like, I don't think it's just one thing. I don't think it's just how long is it on the blood vessel wall, or it's only about the concentration. There's things that we don't know what's going on. Just like with HDL, there are plenty of people with super ridiculously high HDL that develop cardiovascular disease. And so and when people come to me and be like, oh, it's my good cholesterol and it's really high, and my doctor told me because my HDL is high that I don't have risk of cardiovascular disease, it makes my head want to blow up.
But that could be genetic. And also you got to think about it. Then you just proven my point, because what is the cause of this? I'm going to tell you it's visceral fat. If they have a lot of visceral fat, and you got people with skinny fat that are skinny and they have visceral fat.
Sure.
In all cases, when you reduce the visceral fat, we see a reduction in heart attacks.
I kind of think we're saying the same thing. But the thing that I like, I'm like, I just think it's all one piece of the puzzle, and you have to approach these things in all different ways. And hormones are one way from an inflammatory standpoint, from an endothelial dysfunction standpoint. But maybe where we disagree is that I feel that because I look at the data, as you lower ApoB, you get a direct drop in cardiovascular disease risk until you hit a point.
Yeah, and I agree with you on that. And what I'm going to tell you is that I don't even use statins, and I get drops in cholesterol and apolipoprotein B, and that because I give them hormones, and hormones will improve your cholesterol, will improve the numbers, because we're getting this, one of the main factors, visceral fat, but also estradiol increases your good cholesterol, right? Thyroid is one of the best at lowering your bad cholesterol. When you reduce triglycerides, which is a direct window of visceral fat, and if you ever done the triglyceride to HDL ratio,
Yeah, I do, but I've basically gone away from that and
Okay.
mostly just track apolipoprotein B
Okay.
people. Because one, it's simple, and two, there's other reasons, but go ahead.
Yeah. But I use it because it's just a sign of visceral fat. Okay. If they're above 3, very good fact that they may have visceral fat. Okay.
Sure.
So
Sure.
So anything that I can do, I use that cholesterol. The cholesterol is not for me. Cholesterol for me is whether the therapy is working as well. Like you said, I'm looking at their waist circumference. I'm looking at their visceral fat score. I'm looking at their cholesterol. If these numbers are improving on the hormones and they're losing weight and gaining muscle, and I'm doing the best justice I can do for them, if that makes sense. Just simply giving them a cholesterol medicine and not changing any of these other factors, we don't see improvements. We see very low improvements.
I don't disagree with that.
Yeah.
I don't think anybody who's working in this space that we work in of preventative medicine,
Exactly.
if they are just coming at it from only doing cholesterol, which I agree with, so statins can increase people's risk of insulin resistance, but it's sort of waning out, but it doesn't do it in everybody. Some people that's part of the picture of looking.
Do you know how it does it?
I don't think anybody exactly knows.
We do know how it does.
I think there's theories.
No, it's studied. It's been studied.
Okay, all right, let's talk about it.
So your LDL cholesterol is required for your beta islet cells to function properly. When you drop LDL cholesterol indiscriminately, getting rid of all LDL, because there's good bad LDL cholesterol and there's bad LDL cholesterol. Okay, then what happens is you get apoptosis of the beta islet cells. And that's where the insulin capacity reduces, and then you become hyperinsulinemic because these cells become overworked, and that's where you get the dysfunction and you get the diabetes from it. Okay, I am angry because we've known this since 2001. And what is the number one population we put statins in people? Diabetics. So we're worsening their disease.
That's it. For sure.
That's the stupidest thing ever. I'm looking at it, I'm like, why are you giving a statin? Because they say the risks outweigh the benefits, or the benefits outweigh the risk, right? Well, if you're only seeing a 2 to 3% reduction, if you're just giving a statin, right? Nothing else that you're talking about, right? And you're seeing anywhere between a 51%, and I've seen some studies as high as 363% over a 2 to 3 year period increase in diabetes. How does the benefits outweigh the risk? What it is, it's economic. Okay, I don't want to get into an argument, but think of it's a $1 billion.
This is a great discussion.
Yeah, it's a $1 billion industry, if not more. And if all of a sudden you say you're going to get diabetes if you take a statin, right? And it's not really going to help you that much if you don't do anything else with reducing your risk for having a heart attack or stroke. A lot of patients are going to stop it. Any patient that developed diabetes during this is going to sue the company, right? In addition, you're going to see a problem as it relates to, how would I say, you got all these lipidologists that made their career on this. They can't go back and say anything negative. If they were good doctors and people, and I'm not saying they're bad doctors, it's that they believe in it so much, but you can't believe in bad medicine. We got to believe in good medicine. What is the best thing we can do for our patient? They're going to lose their reputation if they come back and say, man, we shouldn't be using these drugs. They want to put it in people's water, like fluoride.
Yeah, I'm not sort of defending or thinking that. I think that maybe, well, first of all, I kind of always had the perspective that it was beta cell function, intercellular signaling pathways that statins think, and then effects on muscle and myopathies that in muscle tissue breakdown, we think, and having an effect on physical activity. There's also sort of effects on liver function that we think, involved in glucose metabolism there. But also, I also think there is a component where the people you are putting on statins are also those that are tended to have a metabolic dysfunction. And so there is some difficulty with the data there. But I think we should move, because I want to talk about other hormone stuff.
That's right.
But
I think we're on the same level. Every time, my mentor is Dr. Neil Rosier. And he said, man, if I could invent a drug that had a statin and testosterone in it.
Sure.
Because he's saying that, you do get some benefit from the statin, but you get giving a testosterone is just as it gives you even better benefit.
But we also, I mean, it'll be more interesting to see, and what we're seeing, sort of counter that, is we have these alternative to statins, PCSK9 inhibitors, bempedoic acid.
Why did you go down this route?
But well, we should. I guess we should if it's going to be painful. But we're seeing reversal of plaque burden in those. Yeah, but
patients. What is the outcomes first? And the other thing is we need to look at outcome studies. In addition, I've seen the PCSK9 studies. The only benefit lasts for about a year, and then it regresses after that. After that, it stops working. And you're like, okay, I just spent this much amount of money because they're not cheap.
Yeah, yeah. They
you see them stop
working cheaper, but yeah.
And then all of a sudden, after a year, the results are the same, or they start getting back to where you need to look at them. They're really interesting studies. I'll have to get to them, the ones that I have.
Yeah, no, I'm just seeing a lot of the studies around quantitative coronary CTAs with quantitative AI, and seeing plaque regression over 2 years, 4 years, and on with. But none of these patients are in a vacuum. Where I am seeing the changes are where I agree with you is people are just being put on statins and then just let go. And they're not optimally being managed. They're not like, people aren't following up on hemoglobin A1Cs. They're not tracking that.
Yeah.
Right? They're not, or maybe they are, but they're tracking it every year, 2 years kind of thing. That's a problem to me. Or they're looking at their LDL, but not following up on coronary artery CTAs and repeat studies to see, are we stabilizing plaque? Are we having the effect that we think?
Yeah. Have you seen the grayscale ultrasounds? They're better indicators of, instead of doing CIMTs, carotid intimal thickness, there's a grayscale burn that actually is more indicative of heart disease risk than even the CIMT, basically. I've looked at some research on that. So that's really interesting. But I think me and you are aligned in the fact that, hey, if you're going to do a patient, you're not going to do one part of it. Right, you're gonna
you're a jackass if you are like that. Would be the dumbest thing ever.
Yeah, that's why. Because when you deal with wild health, you're doing a holistic approach. You're dealing with everything. You're looking at all the data, right? And you're also listening to what the patient says. Same thing with me, my clinic. What I'm saying is, we're simply putting a medicine in somebody's body, and you're agreeing with me on this, and expecting that person to have a good outcome without talking to them, without giving them the proper thing. Because I go through nutrition with my patients. I go through exercise program. I go through the hormones with them, and I say, hey, this is what you got to do. I mean, there is no shortcut around this. I see all these companies come up with this electromagnetic, Mandu, and all these guys doing these things, and I'm like, that's just. I understand what they're trying to do, but the research for those are showing that it only helps with limb. So if one muscle is smaller than the other muscle, it'll help get them equal. It doesn't help with overall strength. That's the all the studies I've seen. Mm-hmm. And so, all these fads and things, it does not replace, and I think you're going to agree with this with anything, is with listening to the patient, exercise and diet and lifestyle changes. In my aspect, to be adding hormones, but you don't understand what I'm saying. It doesn't change those things. You have to still do those things. So
yeah, and I think HRT, TRT, that is just like all the other things we've discussed, one tool in the toolbox, depending on the person. If you're not here, like you started with, if you're not listening to what the person's symptoms are and you're just treating the number, and that kind of goes back to the same philosophy of you're missing the boat, right? And doing hormone replacement on people just based off their number, it has to be a full view of what their symptoms are. But maybe we should just touch briefly, and we should circle back and talk again, because we went way the hell off.
Yes, we did.
What we were supposed to.
I didn't think we were going to go down the statin borehole, but I put you down that one.
So let's talk about. Can you just kind of briefly talk about hormones and cancer, because of the myths around that, and maybe touch. I think this has been beat to death in people in this space around the Women's Health Initiative and sort of misinterpretation of data there. But the other types of cancers people talk about with hormone replacement therapy.
So obviously the breast cancer one, Women's Health Initiative, if you look at it, Europe doesn't recognize it because they don't really use Premarin and progestins, right? Mm-hmm. The Women's Health Initiative was purely on progestins and Premarin, specifically medroxyprogesterone. So the problem with that is, again, I'm going to use the term, I've been using this term as a buzz phase right now, is conflate. What's happening is, you ever heard the term progesterone, estrogen is estrogen. And that's what I hear all the time. So whether it's synthetic or bioidentical, they equate the same thing. And that's what happened with the Women's Health Initiative as far as that. Interesting enough, Dr. Jablowski did a 28-year follow-up with Premarin, and this is a study in JAMA, actually. It's really cool. And they followed the women who continued estrogen alone in the form of Premarin versus women who didn't continue anything. And the incidence of breast cancer in those women was less who continued estrogen in the form of Premarin than women who did not continue any hormones. And the death rate was less in that group of women as well. So if you take Premarin, and I don't give Premarin because of the clot risk.
Right.
I give estradiol. It's going to reduce your incidence of breast cancer. And this is over a 28-year period study.
Yeah.
Versus women not continuing anything.
Mm.
The other arm of the study looked at women who continued progestins with Premarin versus control, which they wouldn't take anything. And they found there was an increase in incidence of breast cancer, but the death rate did not change because we screened for breast cancer so aggressively. So even though there was more cases of breast cancer with the progestin and the Premarin, not many more people died. It was the same. Okay. Why? Because progestins are the culprit. They can increase your risk of a breast cancer anywhere between 2.68 times if you take them. Guess what those are in? Birth control pills. So we're giving these chemicals to our women for birth control, saying they're safe, but they're almost a threefold increased risk of breast cancer. So it was the progestins in that study that was causing it. Prostate cancer. Look up Dr. Morgenthaler, Harvard physician, used to be the head of urology there. I don't know if he's still there. Does a lot of research on testosterone and prostate cancer. A lot of doctors believe prostate cancer is caused by fuel on the fire with testosterone. That would imply the prostate has infinite receptors. That does not happen that way. Up until a 200 level of testosterone, you can stimulate a prostate cancer. But once you get above 200, you see a slow decline, and then also you see a drop-off. Now, if you look at what Johns Hopkins did recently, they had a study in 2017. They did high-dose supraphysiologic testosterone level in patients with prostate cancer, and it actually reduced the prostate. One patient, I think, was cured in the study because they found that there's a receptor that the testosterone binds to that can actually cause a damage to the prostate cancer cells. Okay. We also know what hormone goes up when you give testosterone. The more you give it is estradiol. We used to treat prostate cancer with DES, which was a synthetic estrogen. Okay. We know that estrogen causes apoptosis, which is cell suicide of prostate cancers, and reduces the blood supply. This is why you don't see 20-year-old men getting prostate cancer, because God knows a 20-year-old man has a higher testosterone than a 50-year-old or a 60-year-old. And you would expect if testosterone causes prostate cancer, you would see it in those patients, but you don't because testosterone increases estradiol. We don't block estrogen in a 20-year-old because we don't give them testosterone because we think it's normal to have a elevated testosterone. And in addition, that's going to make your estrogen go up. And that estrogen is protecting those prostate cancer cells, protecting you against the prostate cancer cells. The reason why men get prostate cancer at age 50, 60, and 70 is because you lose that testosterone. You lose that estrogen from testosterone that protects you against that prostate cancer. There is some genetic aspect to it, but when you look at it purely by hormonal standards, testosterone, there's no water that holds that. Now, everybody's going to come back and quote the 1941 study from Dr. Huggins. Remember what I told you? There are studies where you give hormones, and there are studies where you see baseline. In this study, these men had prostate cancer, and they removed testosterone. They didn't give testosterone. When they removed testosterone, the patient got better. But do you know how they removed testosterone? In a subset of their patients, they gave estrogen to them.
Okay. To
suppress testosterone production. Because remember what I told you, estradiol is how the brain controls testosterone from your testicles. So when you give estrogen, you're chemically castrating them, which is dropping their testosterone production. Yeah. And that's how they got that result, right? But if you look at the studies where you give testosterone, the 2012 study from Dr. Morgenthaler, it was a small study. It reduced the risk.
Worried you were going to say, when you asked me, like it was an old study, I was worried they actually castrated them.
No, they did. No, they actually did too. They did both.
Oh, they did that.
They did too. They actually castrated them too. Back then, we didn't have the NIH there to control it. I don't know.
IRB.
Whatever it was. But, but they did. They did that too. And so this is the problem is that I saw, it's kind of like the earth was flat. What you learned before, then you have this confirmational bias. It's harder for me to take a provider that's been trained a certain way and then untrain them and train them in hormones. Whereas if I get a blank slate of somebody who hasn't been, this is why it's easier for me to talk to patients because they've never been trained in hormones. Okay.
Yeah.
It's sort of like Semmelweis. You remember Semmelweis? He was the one that came up with the father of hand washing.
Oh yeah. No. Yeah. I know.
You know that story really well, right?
Yeah.
He was ostracized. Yeah.
Yeah. He ended up dying before he got like.
He died.
Right.
They put him in a freaking mental.
Yeah, that's right. Yeah.
And he died in a mental institute. And now what do we do?
No, it's basically he was an OBGYN, correct?
Yeah, no, he was back then it was all he did OBGYN. Well, it was like
he mostly
did everything.
Babies, and he made the association of the men or the doctors at the time were mostly men checking cervixes on women to see where they were and not washing their hands in between, and then
transferring diseases and killing them, right?
Diseases. Right.
How he found out was interesting. One of his colleagues had a scalpel when he cut himself accidentally with the same scalpel he was using, and he died from the same disease. And he said, hold on a second, something is being transported. Some microbe is being transferred. And he started using a line and washing his hands afterwards. Man, he went in front of the Austrian, he was not Austrian, I think it was Polish or something, but he went in front of the Austrian, the medical board to present his findings, and they laughed him out of there.
Yeah.
Think about what I'm having to deal with right now, right? So I may be ahead of the game, but I've been doing this 15 years.
Yeah.
Dr. Rosier, my mentor, has been doing this since 1983. I hear a lot of doctors say there's not enough research, not been studied. Dude, I have over 50, 60 years of studying on hormones. It's just because they don't want to see it. They have this preconceived idea that this is how it is, and it is. This is where we get there's too much testosterone, or estrogen is going to make your breast. This is why people come to me so I can explain it to them. But the funniest thing about it, I have patients that come to me and say, my doctor won't test this stuff. He says, if I don't need it, I don't need it. I test it. I show that they need it. I replace their hormones. And as soon as they go back to their doctor, what did their doctor do? They start testing their levels.
Oh, they start testing. Oh, yeah. Okay.
And I'm like, dude, you never tested it before. What are you checking behind me? And then once they see that level go above that 1,000 or 2,000 or whatever they're afraid of, they freak out. And I'm like, you said you didn't have the expertise. You said the patient doesn't need it. So what makes you the expert that tells me that I'm doing the wrong thing when you didn't even know what you were doing in the first place to treat this patient? This is what angers me. Okay. I'm very passionate. I'm Greek. My wife tells me to calm down sometimes. But what I try to do to my patient, I say, hey, listen, if you think your doctor knows this better than me, go with him. I always tell them, you're not going to go to a podiatrist for a cardiac surgeon. So why would you go to a regular doctor for hormone replacement when I'm the specialist? A lot of patients get disenfranchised because they don't get listened to, and they come to me.
Yeah.
And they're looking for help, and I help them. But then the doctor gets pissed off because I help them. Because they think I'm going to give them a heart attack or cause osteoporosis because I gave them thyroid.
Or breast cancer.
Or breast cancer, exactly.
That's a common. What I want to put it, we should look this up, and then we'll talk about the things we're going to talk about the next time we talk. But
okay.
I just want to clarify just for patients out there, you were talking about in women with around breast cancer risk, you were talking about progestins and synthetic hormones that mimic the action of progesterone, but there's not data that progesterone, not the natural progesterone, doesn't cause breast cancer. Is that correct?
There's several data that does the exact opposite.
Okay.
It upregulates the P53 gene. It reduces a lot of proto-oncogenes. So it actually does the X factor. There's actually receptors on the breast that progesterone actually helps cause cell death and reduces the risk for breast cancer. The only commonality between progestins and progesterone, and I'll explain to you, is reduction of uterine cancer.
That is true.
Yeah, that's the only commonality. Okay. It is hilarious how many doctors will tell their patient, ask him why the hell he has you on progesterone if you don't have a uterus. Because all they're thinking is that progestins are the same as progesterone.
Right.
But believe it or not, progesterone is going to help with body fat.
Right.
Yeah. Progesterone helps with breast cancer. It also helps with ovarian and urine. Yep. Oral progesterone is phenomenal. We as men wish we could take progesterone, but guess what? There's studies that show that progesterone in men is pro-inflammatory to our blood vessels. You don't want to take oral progesterone as a male or even sublingual because it's going to cause inflammation on your blood vessels. What does that translate to? It could translate to you getting clots, a heart attack, or stroke. So we don't want you to take that, right? I don't give progesterone to men. And I had men come to me, oh, I was giving progesterone because it helps reduce my aggressiveness. Well, we used to give progesterone to men in jail as a saltpeter.
Yeah.
That saltpeter to reduce their libido and aggressiveness. That's why we gave it. But we kill people doing that. We don't want to do that to them. Progesterone reduces the risk for, also helps with depression and anxiety. One of the best hormones for women for depression and anxiety is progesterone. Migraines and headaches. If you have a woman developing headaches after menopause or during perimenopause and never had headaches or migraines before, I can guarantee you that's probably going to be a hormone issue, especially progesterone. So it's a lot of benefits. And along with estrogen, this was in combination with estrogen, it can actually reduce your risk for heart attacks.
Yeah. So, okay. I just wanted to clarify around that because it's important to clarify because patients. Yeah. So we've been going on for over an hour here. So I'm sure people are like, what? It keeps going. But so I'd like to circle back and talk again at some point about estradiol in men, testosterone in women. There's a couple other myths, but we touched on a lot of them in discussions. But then, and talk about a little more about what you all are doing and your kind of a personalized approach to things, and also thyroid, and kind of like double click on thyroid disease and thyroid replacement therapy and current kind of thought processes around that.
Yeah,
does that sound good?
Yeah, man. Anything you want to, I'm always available. This is my first podcast. I guess I'm the least known expert in this medicine because I'm kind of like the Wizard of Oz. I put my head down, see my patients, and I'm pretty much dedicated to my patients and stuff. And you could ask them, if you ever get to meet them. And I'm trying to help as many people as I can. And so they want me to be more out there. And I've done a few videos, I've done a few radio shows, but this is awesome. I actually, believe it or not, I think you and I are more like-minded than they may think we are by this talk, So.
Yeah. Oh, you mean people listening? Yeah. No, I agree with that. But I mean, there's a lot more to unpack here. And I think I led with that. Like, this is a really hard area where there's lots of different opinions and strong opinions about. And this is great to have this conversation.
Yeah, but I don't look at the opinions. I look at what the study showed.
No, for sure.
Because that's the only thing. That's the only way I can defend myself, right?
Yeah. What I should say is there's different interpretations of data.
Yeah,
for sure.
Yeah, but if I go in a court of law and somebody brings in one study that's a baseline study, and I bring 15 studies that show interventional studies, what do you think is going to believe? But yet, in traditional medicine, they believe the person that says that one study, right? A good example before we leave is the vegan study, which was the insurance database study done in veterans that purported that we increased risk of heart attacks with taking testosterone. This is a bad study because it was actually an interventional. It wasn't an interventional study. It was a insurance database study. Insurance database studies are a relatively new type of study because really we didn't start looking at insurance database studies till the early 2010s, something like that. And basically, they look back in a computer, see whether somebody was given a prescription for testosterone, and saw what happened to them, whether they had died or had a heart attack or whatnot.
That sounds like a terribly done study.
But yet, this is what you're going to hear from all people that oppose testosterone and think that it causes heart attacks. Look at the TRACE study, TRAISH, in 2017 in the cardiometabolic. It was a cardiometabolic study. In that study, I think it was a prospective cohort study. So a little bit better study, probably a grade B study. In every anthropomorphic number, so it looked at cholesterol, looked at blood pressure, look at waist circumference, look at weight, look at sugar, you see compared to men who did not take testosterone, all those numbers reduce and improves. If you improve those numbers, how's that going to make you increase your risk for heart attacks? Even funnier with the vegan study, and this is what I hate with a lot of doctors, and I used to do this a lot. I'll look at the abstract, look at the discussion, and say, oh, that's what it is, right? Because I got lazy.
Right.
Yep.
Right. Yeah.
But look at the vegan study and look at the results. The raw numbers showed a 50% reduction in all-cause mortality, a more than 50% reduction in strokes, and a 50% reduction in heart attacks. Yet, because of the statistical tool they used, they flipped the number and they said a 28% increase in heart attacks. Incidentally, in that study, 10% of the population, or 10 to 25% of the population were not men. And in the title of the study is testosterone increases the risk of heart attacks in men, something like that. It was 10 to 25% of the men were women. So whenever you hear a doctor say there are studies that show heart attacks, I've only ever found 3. 2 are insurance database studies, the PLSO1 study and the Finkelstein study. The Finkel study. The Finkelstein is the good study. It's funny how they have a similar name. The Finkel study. And then there's a review study that show the same thing. Look up Dr. Molly Shores.
Okay.
She looks at all the grade D studies. She does a review of all the grade D studies as it relates to testosterone and heart attacks and clots. Okay. She showed, even with those bad studies in there, overall, and these were grade D studies. These were like your insurance database does. She showed that there was a reduced risk in heart attacks or a neutral effect on heart attacks. And then the clot risk was insignificant. Yet we want the controversy. They won't remove that study from JAMA because it sells ad space. There's been letters from doctors. Morgenthaler is one of them. Trace that sent to them and said, y'all got to remove this study. This is a bad study. You're giving doctors wrong information. And yet they still haven't removed that study. So I have to sit there and explain to patients about a bad study.
It's hard. We actually.
So so I can go into a lot of stuff like this if you want anytime, man. It's just what do you believe? What you can interpret. What do the studies show? That's why people come to me is because I do look at the studies, and I have patients that come to me and I'll leave it this, that their doctors say, oh, this is going to cause this. Then I say, show me the study. And their doctor won't ever send them a study or give me a study. And then I say, here's 5 or 6, 7, 8 studies you can look at. And if you want to give it to your doctor, you can. But usually what ends up happening, you end up killing a small tree because you send them with the paperwork. Now I try to email it to the patient. And then the doctor never looks at it because they don't have time, Yeah. So,
well, I
sorry.
think that actually, no, this is perfect. I mean, I think a lot of those studies we should link in the show notes. I think we sent some of those our way ahead of time, and we should link those in the show notes, and so patients have access to them that are listening to us. So
how do I email that to you?
Well, we could talk about that offline.
Okay. Okay.
So let's. That sounds great. I'm really glad we had this chance to meet and talk. It was a great spirited discussion. So Peter, thanks again. Dr. Peter Fotinos. Let's do it again, buddy.
Yeah. If you want me back, man, I don't.
That's sure. I love this. This is great.
It was great having me, Carl. I mean, and you don't look like Ned Flanders. I agree. You look like look like Doc Holliday.
Yeah, you heard that story. Yeah.
Which Doc Holliday? We're talking about the one. Was it Dennis Quaid, Doc Holliday?
No,
we're talking about Val Kilmer. Doc
Val
Holliday.
Kilmer. Yeah.
Hell yeah.
Of course. Yeah.
Val Kilmer is young age, right?
Yeah. Not now.
Not now. So, that's not good.
Right.
Sorry.
All right. Well, thanks so much for being with us.
Thank you, man.
That's all for this episode. Thanks everyone for listening. And if you're looking for more, be sure to follow us on social at WildHealthMD and head over to wildhealth.com or wildhealth.com/premium to become a patient and experience precision medicine for yourself.